Hello, everyone, and welcome to another episode of Teeth Matter, the podcast where we talk about the highs, the lows, the truths about what it means to have a career in dentistry. I'm your host, Ellie Halabian, DDS, and today we're exploring the crucial field of airway dentistry. This is now a hot topic. It's something that I'm just learning about, and I'm very excited to share with you. And in today's episode, I'm joined by Dr. Victor Khatchaturian, founder of Sunset Dental Studio in West Hollywood. With a strong focus on cosmetic and restorative dentistry, Dr. Victor also has a deep passion for airway health and its impact on overall well-being. So in this episode, we'll break down what airway obstruction really is, the clinical signs you need to watch out for, and what it means for restorative dentistry. We also chat about the range of treatment options, from simple interventions like mouth taping to Botox to even more advanced surgical approaches. Understanding a patient's airway isn't just about breathing. It plays a fundamental role in their dental health, their treatment outcomes, and their overall quality of life. So if you're not evaluating the airway, then you're missing a critical piece of that puzzle. Let's get into it. Hey everyone, you know I'm all about keeping it real when it comes to life inside and outside the dental world. And let's be honest, good sleep, solid health, and keeping our mood in check are what keep us functioning at our best. So, I put together a list of my go-to products, the ones I actually use every day to help with all that. If you're looking for game-changing sleep essentials, wellness must-haves, or little things that just make life better, check out my affiliate page. Head to teethmatter.squarespace.com/store to see what's in my daily rotation. Plus, if you grab something from the list, it helps support the podcast. That's a win-win. Thanks for being here, and let's keep leveling up together. Dr. Victor, welcome to Teeth Matter.
Thank you so much for having me.
How are you? How are you doing? I'm excited to chat with you.
I'm excited too. I'm doing well. It's been, we were talking, it's been an interesting time in LA, but things are kind of settling down and I'm one of the lucky ones. So I have no complaints and I'm thrilled to be able to do this.
I'm really excited to chat because you work in LA, you have a very beautiful practice, very aesthetically pleasing practice, but you have also a very interesting scope of dentistry. Tell me about your practice and what kind of dentistry you do.
Okay. So, well, thank you. Thank you for the compliments. So my practice started as a semi-stereotypical, just cosmetic, veneer heavy, West Hollywood, Beverly Hills practice. We're literally on the border between those two cities. So the most we're literally in the building where the first veneer was ever done. So that's the heritage of the city, the location. So very stereotypical what you think it would be, right? And then as my continuing education evolved, and then my interests evolved, the office has come along with it. So to people that have come to me in the last year and a half or 2 years, I'll actually have people from time to time say, like, do you do veneers? They have no concept that that's my bread and butter, but to them, we're a holistic office. We're a functional office. The word that gets thrown around the most is that we're an airway office, and I know we're going to talk about that. So I'm really, really proud of what it's become because I think it's very unique what we have here. We're trying to bridge a very interesting gap between aesthetics and health.
Airway dentistry, as I mentioned to you offline, was a new term for me. It's something that I've been hearing about more and more recently. So can you describe what is airway dentistry?
Yes, I actually love to. This is particularly important to me. I learned the vast majority of what I know about airway from Jeff Rouse. He teaches a course at Spear, and that opened the door to a few different places. So in 2016 or so, when I came across this, it was still kind of the black sheep, very minority thing. Now it's become a lot more popular. But as things become more popular, it's almost like your favorite band. Like it was your secret, and now everyone knows about it. And so there's a little bit of that feeling to it. But what's happened along the way is people are taking this term and kind of using it in the wrong ways. So airway dentistry there's a bi-directional relationship, meaning what happens to the airway affects what's going on in your in your dental occlusion and your dental health, and what goes on in your dental health as a direct relationship on what's going on with your airway and your ability to breathe. For the dentist in the audience, it's the effect of the airway on the stomatognathic system. That's what it is. What it's being kind of used for is there's been a world of sleep dentistry that's existed before what airway was, and they're seeing the kind of popularity or the rise of this term airway dentistry, and they've kind of co-opted this term. So a lot of people will use airway to describe doing sleep appliances for people, which is, it's indirectly correct. So if someone can't breathe well, they're not sleeping well. But if you're doing airway dentistry, your goal is to not just focus on their sleep and make sleep appliances. You're doing dentistry that is conscious of the airway. Was that too complicated?
No, you said everything, and I can follow through. But you used a very big word, and I'm going to ask you to define that. You said stomatognathic dentistry. What is that?
So your stomatognathic system is going beyond just your teeth. You're looking at your hard palate, your soft palate, your everything in from behind your lips to your hyoid bone down here somewhere. So when we think about, grinding our teeth, we always just think about it as it's our teeth that are grinding, and it might affect the TMJ, but we don't think about what are all the structures around this. When I went to dental school, you were talking about airway wasn't around when you went to dental school. We didn't spend any time thinking about what relationship the tongue has to do with anything, other than you check for oral cancer and stuff like that. But I never once heard about a swallowing pattern till I was about 12 years out of school. So these are all parts of this stomatognathic system. It's all the stuff that you probably look at when you're doing an oral cancer screening for somebody, but understanding what role they play in your everyday dentistry.
You mentioned it. You may have some physiological features that affect the way your occlusion comes together. Now, you said that a lot of people relate this to sleep or interrupted sleep. What are some of the other physiological impacts of poor occlusion?
So, well, and I would say that the poor occlusion, like I was having a conversation with like a really, really intelligent dentist from Brazil, and we were talking, and he understands occlusion better than I ever will. But the question that I threw him off was, well, why do we have malocclusion? We don't think about this as other animals, other than the dogs that we've bred and we've become responsible for. Other animals don't have malocclusion. If you look at another animal, they have perfectly straight teeth, unless we've messed with them. So like English bulldogs are my favorite dogs, but they're in bad shape. So I would go back a step and say what we think about when we talk about occlusion and why someone even has it in the first place is typically due to something else in the system going wrong. It's whether or not their lower jaw grew to the right place in the first place. If they were able to swallow properly, if they were breastfed, if their mouth grew in a healthy way to allow for those teeth to come out into a proper occlusion in the first place. So when I look at a malocclusion, I'm always asking myself before I dive into the details of that occlusion, why is it there in the first place?
So why is it so important? Why is airway dentistry so important?
Great question. So how I got into it, how I originally got into it was for the most selfish reasons. And then that reason changed as I had a son around the same time I had my first kid, my only kid, around the same time I was learning all this and understanding what this does to kids. And that became a passion of mine. But I got into it for the most selfish reason, because I knew that for somebody who's putting porcelain all over people's teeth and all over their mouth, that a night guard doesn't stop these things from chipping and breaking. So I got into it out of self-preservation. I didn't want my stuff to break. I didn't want to deal with upset patients. I didn't want to have to deal with redos. And inevitably, I had taken, all the occlusion courses you could, and which is to say it's a kind of a giveaway that, we all agree, like in the endodontic world, for the most part, there's pretty much consensus. Like if you do these certain steps and you finish a 0.5 millimeter from the apex, you've done a good root canal. But there's about 8 different occlusion courses because they can't even agree with each other.
Right.
So that's kind of a giveaway that it's not a perfect science. And for me, I originally got into it because in short words, if somebody's mouth isn't where it's supposed to be, and we disguise it all day with veneer. So somebody comes in with a narrow arch, like the most common thing you'll see on Instagram is somebody with like a narrow smile, and then they get porcelain veneers on the outside of their teeth, and all of a sudden they have this big, beautiful, broad smile, and it looks great, but nothing changed structurally. And if we don't change things structurally, whatever caused the damage that made them want that cosmetic makeover in the first place, it's going to happen again. If that makes sense. So,
yeah, it makes total sense. I was going to ask you, you mentioned narrow palate or narrow arch being one of them. What are some other clinical signs that your patient is a mouth breather or has obstructed airway?
fantastic. So, couple of things that we'll look at is the first one is obviously the width of the arch. So we'll look at the distance between upper molars, upper first molars, and see what that is. And you typically want that to be about 38 or above. And there's some argument about what that number should be, but you're looking at 38 or 42 millimeters, somewhere in there, and anything above that is great. What we look for when we take like a profile picture, we'll always look at tongue posture. So when the lips are together and someone's just at rest taking a picture, we're looking to see, is their tongue down here? And that's a dead giveaway that, that's where that person is when they're at rest. When we talk about sleep or evaluating someone's airway, a lot of times people will get a CBCT and look at the back of the throat, which is perfectly fine. But more often than not, when someone's getting a CBCT done, they're in the most unnatural position. They're biting on a bite fork or they're posturing in a weird way. And that doesn't tell you what they're doing in day-to-day life. But like, as you and I are just talking together, when you're thankfully listening to me right now, as you're just at rest, you're doing what you do most of the time. And that's something we look for, is where's the tongue when we're looking at a profile picture? Is the tongue in the right place? We're looking at the muscles around the lower jaw. We're looking at the mentalis here to see if there's mentalis strain here. That's another dead giveaway that the person has to really force their self up, get their lower lip to their upper lip. And that's lip incompetence is not the ability to be able to close your lips comfortably. So we have a really derogatory term for this, so I don't want to be too controversial, but resting B-word face is somebody who's having to forcibly put their lip together. And the reason you do this is to be able to breathe through your nose comfortably. So we look at it from aesthetic, there's some aesthetic cues, like things like that. One of the biggest industries we know of in cosmetics is like lip filler and lip enhancement. So when somebody has a really thin upper lip, and I'm a good example of this, that's another sign that their maxilla, this upper jaw, didn't project forward enough to support their lip.
Interesting.
Which is a lot of the aesthetic, I see that that's news to you. And a lot of the aesthetic world and a lot of the aesthetic enhancements that are going on that people do for kind of superficial kind of reasons, they're all airway related. They're all airway development related in a way.
That's fascinating. I didn't even consider that, some of these cosmetic procedures are actually trying to fix a more physiological problem, if anything. When it comes to these clinical signs, you can see them clinically, but do you also do any kind of tests, like with the patient, or any other evaluations to determine whether the patient is, I guess, clinically airway obstructed?
Sure. So truth is, not as much anymore, and I'll explain why. I think that deserves some explanation. One of the biggest hurdles in getting people to adopt this is the more steps, and I think you'll say from your experience in Cs, the more steps you have to go out of your regular protocol of doing things, I think the less likelihood there is for adoption of those techniques. If you just have to go home and buy a couple of new composite instruments, you're probably going to do that. But when I first incorporated this into my practice, we wouldn't even see anybody until they took a sleep test. And what ended up happening is patients kind of had a hard time with that because, they maybe weren't as interested in it as I was, which is kind of frustrating sometimes. So, and then as more dentists try to adopt this, and it's perfectly fine if somebody wants to do that. But what ended up happening is the more testing you have to do, the higher likelihood it is that someone's going to not incorporate it into their practice. So like the age old common problem is people will buy a piece of technology and like it's just gathering dust, like my Peloton, like it's just sitting in the corner. A lot of people say that about their CEREC, Yeah. So the goal of airway dentistry and how it distinguishes itself, at least in how I've adopted it from sleep dentistry, if you're going to make somebody a mandibular advancement device, you need to have sleep metrics because that's your goal. You are specifically trying to make sure that they sleep better and that you are attacking their AHI level or their apnea level, in case your listeners aren't familiar with these terms. With airway dentistry, I'm looking at these cues to make sure that I'm not making anything worse. I'm definitely not going to do anything that makes somebody worse, which is a really common thing. Well, we should go into that. But there's a lot of common things that we do in a daily practice that actually makes people worse from an airway standpoint. So I make sure I'm at the bare minimum, I'm doing no harm. And then if nothing else, I'm setting them up to be in a better position to breathe. So long answer to a straightforward question. I actually don't do any sleep testing anymore. I just look at what's going on physiologically, what's going on anatomically, and use that to determine where I want things to be.
I have a silly question. Is sleep apnea different from an upper airway obstruction?
It's part of it. So if you have an upper airway obstruction, you have a really high tendency of developing sleep apnea. So sleep apnea has a very, very specific definition. It's a closure of your airway. And depending on, if you're using Medi-Cal or insurance, it's a 90% closure for 10 seconds or more. It's a very uniquely specific definition. But it misses a lot of things. So you can have an upper airway obstruction. And this is actually why I don't test, because young women like yourself, and there's a long explanation for this, but I'll just tell you the short version is that more often than not, young, healthy women or seemingly healthy women don't have that kind of closure for 90 seconds or 90% for 10 seconds or more. So there's a huge group of the population, which is women and kids, who could have a 50% closure for 30 seconds. And if you were to talk to somebody who's focused on apnea, that's not apnea. You're fine. So that's kind of the elephant in the room is there are people that are significantly underdiagnosed or potentially misdiagnosed because they can have an obstruction and not breathe all that well. But if they don't fit into this very, very narrow category, they're deemed as fine. It's black and white. And in healthcare, for insurance purposes, things are black and white. But in reality and in healthcare, things are usually in the gray. They're usually in the middle.
Have you noticed a difference between males and females? Is there one group or one category that happens to have this more?
I wouldn't say that. It's hard for me to say if it's more. I think it's equally common in both, because as a species, our jaws are not growing as wide and as forward as they used to. This has been going on for hundreds of years. As our food has gotten softer with agriculture, we don't chew on these hard foods as kids, and breastfeeding has become less and less common. So we don't grow as far forward. So everybody's having this issue. The interesting thing to me, as like the whitest male, is that I will get caught. If I have this problem, my issue will be recognized, because how we demonstrate it between the genders is completely different. So men are more likely to snore than premenopausal women. So men will snore, men will have apnea, and there's a whole insurance system and medical system built to find my problems. But women get overlooked and kids get overlooked significantly because the way we demonstrate our airway issues.
What are some treatment modalities for airway obstruction?
So it depends on the severity, right? So there are times, even though I don't necessarily test for it, somebody's anatomical structure or their function is so poor that I'll refer them to a sleep specialist or to an ENT. So we do work as a team. Mm-hmm. If somebody is in a severe situation or they have severe sleep apnea, sometimes like the far end of the scale is somebody actually needing double jaw surgery. So that's as kind of hardcore as it gets. Yeah. And that's not new. That's been around for a long time. What's kind of interesting and why airway is kind of gaining traction is the treatment modalities have changed in the last number of years. So if you were in that category, the biggest part of the bell curve is not the people that have the severe stuff. The biggest part of the population are the people that have that kind of subclinical, sub-apnea issues. And up until recently, there weren't a lot of treatment options for that. So on the upper end, you're talking about double jaw surgery. Shy of that, there are now orthodontic appliances, whether they go by different names, MARPI, MSC, different things, but they're basically palatal expanders.
All right, let's talk about something we all know and love, FIGS scrubs. FIGS is the go-to brand for healthcare professionals who want to look good, feel good, and perform their best. Whether you're on your feet all day or tackling tough tasks, FIGS scrubs offer unmatched comfort and durability, all while looking incredibly sharp. And because you're listening today, you can snag 20% off your next order using the referral code in the show notes. You already know FIGS is a trusted brand in the industry, so why not level up your wardrobe while saving some money? Check it out and use that code for your discount.
So sometimes just doing palatal expansion on an adult, which was up until 10, 15 years ago, used to be thought as impossible. Once your upper jaw was quote unquote fused, it was supposed to be impossible to expand the jaw. And that changed maybe about 10 years ago. So shy of doing a hardcore jaw surgery, you could do palatal expansion. That's significantly less invasive. There's less than that. There's even the one that's gained a lot of traction, particularly on social media, because there's a lot more people advertising, is myofunctional therapy. Just doing physical therapy associated with breathing. Sometimes there's no surgery. Sometimes there's no expansion. It's just using all those soft tissues we were talking about the stomatognathic system, using the tongue and the cheeks, and doing physical therapy for the mouth just the same way we do for the rest of the body. But just therapy alone makes a tremendous difference for a lot of people.
You mentioned that your bread and butter was veneers. Now a patient comes to your office, is in the chair, and do they get caught off guard when you start focusing on their airway when they're there for a new smile?
I've gotten better at it. So when I first got into this, it was horrible. I came in, I would tell people I wouldn't work on them unless they had to get a sleep test and potentially go do jaw surgery. Otherwise, I wouldn't treat them. And not to focus on the business side of it, but at some point it was, that was kind of harmful. I was turning away patients. And then at some point it dawned to me, now everybody's patient base is very different. So I already had built some level of a reputation before going into this. So people already knew me for doing cosmetic stuff. And where I am situated as an office that's kind of how patients lean, is they'll prioritize, whether they're right or wrong, they prioritize the beauty over the aesthetics. I mean, the aesthetics over the health, right. Pardon me. So truth is, I told you I got into this around the same time I had a kid. I realize sometimes when I had to give my son some medicine he really doesn't like I'll hide it in like candy or ice cream or something like that.
Yeah.
And that's my approach now with airway. So there's a subset of patients that come to me specifically for this, but now all it's done is changed how I treatment plan my cases. So my pitch, so to speak, with my patients is, if you want the best looking smile, this is how I'm going to get you there. And you might notice you might notice an airway benefit. You might notice you sleep a little better. You might notice that breathing's a little bit easier for you. But in order to get you to the best you're going to look, these are the steps we should take. And that's I've gotten higher adoption by approaching it from an aesthetics first approach. And then that's the ice cream, and the airway is the medicine. It's hidden underneath the treatment planning.
That's a great approach. But is there any age where it's like too late for the patient to have this kind of treatment done?
Short answer is no. It's at any age you want to be able to breathe better. It makes it, just being able to breathe makes every other physiological process of your life better. So, the one of the things that always interests me, not to be a downer, but we all know that like early onset dementia, Alzheimer's, those numbers are like through the roof. And when you go into a lot of the research, there's a huge connection between that and how well those patients breathe.
Right.
And, when you breathe, the first place that air is going in, ideally through your nose, is up to your prefrontal cortex, the first part of your brain. And that's the area that's most diminished in elderly patients or people with early onset Alzheimer's and different forms of dementia. So if anything, to me, like, I think they stand to benefit the most from it. Now, obviously, we want to look at the invasiveness of the treatment that we're recommending based on age. But, these newer techniques, these newer custom designed MARPI techniques, we're getting non-surgical expansion of the palate in people in their 70s. So I would say no, that anyone could benefit from this at any point.
It's interesting how important sleep is, and people don't understand that during sleep, not only if you have interrupted sleep, you're starting to lack oxygenation to your brain. You mentioned the prefrontal cortex, that's where your executive function is. So to have that disruption really affects or impacts not only your execution, your decision making, your ability to react to things, but also your longevity. And so it is a domino effect. It all basically links to one another. What does it mean for restorative dentistry if you just go ahead and do restorative dentistry and think that you're fixing occlusion? What effect does that have?
Okay. So, it's literally, I think this is the best example of like thinking outside the box. And by the box, I mean the dimensions of somebody's upper and lower jaw. So when somebody comes in and they have tremendous wear of their teeth from malocclusion, if you're not taking into account airway, all the techniques that we have are working within that patient's given box. Mm-hmm. And what airway says, I mean, it's a little corny, but you're literally thinking outside the box. You use different anatomical structures of the face that we've always used for aesthetics. And that kind of tells you where things should be. Mm-hmm. So if somebody comes in and you have no idea what I'm talking about, and you've taken a bunch of CE courses and you give them whatever you believe in, bilateral balance occlusion, canine guidance, and all these things, if they have occlusal wear and you just build them back up again, mm-hmm. well, you're just setting them up to do the same thing that they did in the first place. It's just going to happen again, just later on down the road. Whereas if you actually put their jaws in the right place to begin with, mm-hmm. you have a chance to eliminate this. And I always put quotes around parafunction, but parafunction to me is something that we've given this weird label to. There's no other part of your body. I'm going to say that again in case you're editing it. There's no other part of your body that has parafunction. Nobody's knee has parafunction. Nobody's shoulder has parafunction. Either things work or they don't, or they dislocate or they break. But parafunction is basically something we've come up with to explain the things that we can't explain. So if somebody grinds their teeth, we go, well, that person has a parafunctional habit. If you go look at the literature from sleep medicine, because the thing that I want to say is that dentistry and medicine obviously are siloed separately. You go to different schools, right? Mm-hmm. And because we're in our two silos, we're not aware of what each other are doing. We're working on the same house. We're working in different departments of the same house, and we don't know what each other is doing. And one has an effect on the other. So you look into the sleep literature, and they will very casually say, oh, this person has nighttime bruxism as an attempt to open their airway, to keep their airway patent. They know that's what it's for. Mm-hmm. But we're over here trying to figure out, are you grinding your teeth at night because you're stressed? And I said that for years. And it never dawned on me that, well, you can't be that stressed if you're asleep, mm-hmm. And so it's one of those things. I used to work, part of USC was, we had these outreach programs, and I worked at a VA, the local VA here. I worked on people who, were being shot at and sent into war zones, and a lot of them didn't have any grinding of their teeth. Like, they were pretty stressed. So, there is no direct stress correlation to bruxism or grinding, but we'll look at somebody's worn down teeth and go, okay, but if I just put this cusp in the right place, you'll stop doing that. Mm-hmm. And I find that that's rarely the case. Most people that I know will do their rehabs, will do whatever they do in their practice when it comes from an occlusal standpoint. Yes. And this is the thing that I say that makes people upset, but I think it's good to get people to pay attention. If you have control over somebody's teeth, mm-hmm. upper and lower, if you have complete control over somebody's occlusion, and these occlusal principles work, well, then why would you have to put them in a night guard after? If technically, if the teeth line up in the right place and that should eliminate the parafunction, well, then why do we still need to give them a guard to wear after? Shouldn't that solve the problem?
Right. So do you think a night guard does more harm?
I think for some people. So, and that's something that we go into. I don't want to plug my course, but we're starting a course in April. But that's one of the things we want people to be able to understand. Everything in the world and social media is very black and white. You're either pro this or anti that. And for the most part, I don't do a lot of night guards. There are people who night guards make worse. They exacerbate that situation. There are people that cannot sleep without their night guard. And there's an airway reason why. So the person that spits out their night guard in the middle of the night, in short, is the person that can't breathe when they have their night guard. The person that can't sleep without their night guard, if you take it away from them, I think everybody has that patient that gets nervous. They're like, if they need a repair, they'll be like, am I going to be without my night guard? Why they can't sleep without it is that helps them posture into a position that helps them breathe better. So for some people, it's amazing. For some people, it's terrible. But the problem in my eyes is that, nobody's really taught beyond, whatever night guard they learn first, they make that night guard for every single patient. No, there's not a ton of science behind night guards, and there's not a lot of thought. I hate to say this about our colleagues, but there's not a lot of thought. People come in, typically, if you can ask somebody, what night guard do you make? And you'll get different answers from dentist to dentist, but each dentist will typically make the same one for all their patients.
Right.
And some people, it works for some people and it doesn't. And what we do, unfortunately, and I'm bunching all of us together, and I used to do this, is blame the patient. They can't tolerate the night guard well. They're not doing what they're supposed to do.
So who's a good candidate for a night guard after restorative work, or just in general, I guess?
Somebody, well, in short, more often than not, you don't want to put it on a class 2 patient. Like my chin is set far back. I'm actually an airway patient, but your class 2 patients aren't typically going to be your good night guard wearers, because since the night guard doesn't allow you to occlude as far forward and as far superiorly as you're used to, well, where does that jaw go? It goes further back into the airway. So somebody who's skeletally class 1 or potentially even class 3 is going to do fine because their jaw is a little bit further away from their airway. So they'll probably be able to tolerate it better.
Now, what about TMD? You get a lot of patients who come in, they have, I have TMJ pain. I've had it for years. It doesn't get better. I've done this and that, Botox, night guards, all these things. What do you have to say about TMJ? And is that a symptom of airway obstruction?
So it can be. So this is kind of a, there's a lot of overlap. So if we had a Venn diagram of those two, there's like huge overlap between those two conditions. The TMJ, it's a question of chicken or the egg. So the TMJ people would tell you that TMJ dysfunction starts first, and sometimes it does. There's something we don't really learn about in dentistry because, again, we're a little siloed from medicine, is a lot of times just during childbirth, how the child's removed can have an effect on the TMJ. I'm as asymmetrical as you could ask for. So just little things, just basic things that we take for granted. Childbirth could throw off somebody's condylar growth. And if that could have a downstream effect of, well, your jaw doesn't grow symmetrically or as far forward. Well, then in that particular case, TMJ came first, airway came second. But if we're zooming out and looking at us as a species, we know that, like I mentioned, we know as a species, our jaws are not growing as far forward and as far wide as they used to. So if you were kind of blindly diagnosing somebody, I would say that the airway dysfunction usually comes first, but there's exceptions to all the rules. But if somebody can't breathe well, and this is something that, I want to be able to deliver properly. If somebody can't breathe well, they will do everything they have to do to breathe well. So, one thing we don't think about is like, we say, well, somebody's tooth was high, so they were grinding. That's something I learned. So I'm going to go back and do an occlusal, adjustment to it. Well, I learned this from Greg Kinzer, and he's done meta-analysis on this. But if something hurts, just common sense, if something hurts anywhere in your body, you don't go put more pressure on it. So why your body would choose to put itself in a painful position is something has to supersede that discomfort, and the desire to breathe is going to supersede everything.
I heard somewhere that parafunction is actually a protective function.
It absolutely is. So again, perfect segue. You're quite good at this. So it's parafunction is your body doing what it needs to breathe, right? So I kind of indirectly answered your question about the TMJ, but if somebody like me who's a bit class 2 is set back and I can't breathe as well as I should, my body's going to do what it needs to do to breathe properly. And that potentially is to posture my jaw forward into a unnatural physiological position. Like I will potentially dislocate my jaw joint to create the airway I need to breathe, because that's going to supersede all else. So parafunction is a great way of describing the different things that we do to breathe better. Mm-hmm. So it is absolutely protective.
What do you think about mouth taping? It's all the rage right now, whether you have sleep apnea or you have obstructive airway or you're an athlete and you think it's like the new trend. Is it beneficial or can it do harm?
What I think about mouth taping is I should have started a mouth taping brand 7 years ago, but I'm not a good entrepreneur. No, I think it's great. I would say so. This isn't an official study, but your listeners are going to have to take me on their word. I tracked this from 2017 to 2021. I called up all my night guard patients, or when I would see them on their recalls, I asked them to start mouth taping to do a 2-week trial of mouth taping. And 60% of my patients no longer had to wear their night guard. So I'm a huge advocate. Now, the course that I initially took with Jeff Rouse. He has a protocol that he developed, and the first step of that protocol is mouth tape for 2 weeks. So that's where I got it from. But we were talking about what interventions are there. So if at the very far end of the airway spectrum is doing double jaw surgery, the least invasive intervention, step one, is start with mouth tape. So I'm a huge fan.
When you said you did your own studies with your patients, how are you tracking their sleep, knowing that 60% no longer needed their night guard?
So this was early on in my adoption of the airway stuff. So when I was a little bit more concerned with the statistics of it. So this is when we would send patients home with different sleep devices. Mm-hmm. At that time, we were sending people home. There was a single lead EKG. It was called a cardiopulmonary coupling device. It's turned into, I have an Aura ring. So now there you go. Yeah. So one of the things that came from this is in 2016, the concept of measuring somebody's heart rate variability was kind of laughed at, because in medical insurance terms, they don't care about heart rate variability. All they look at is apnea level, apnea level, apnea level. That's it. That's the gold standard. But when we talk about the data tells us that our heart rate variability tells us so much more. It paints such a more complex picture than just the black and white of somebody's apnea level. So that's what we're using, was the heart rate variability numbers that we were getting from those patients. Then secondarily, it was asking, just anecdotally, how do you feel? And people would tell me, well, I noticed I was waking up a lot more refreshed. And even your avid night guard wearer, by definition, is not in their physiological position. They have this piece of plastic, this 3 millimeter piece of plastic between their teeth. So by definition, they're not where they should be, right? So inevitably, even the people that love their night guard are a bit sore from wearing it. So they would tell me just anecdotally that they felt better. They didn't feel sore in the morning. They felt more refreshed in the morning. And then we would look at the data and be like, you know what? It's perfectly safe for you to stop wearing your night guard.
Could you define heart rate variability for me and what it is the measure of?
This is the one you're going to have to edit out. This is the hardest thing. So the one thing I can say about heart rate variability is like one of the hardest things I have. I could pretty much define all the other terms in the airway world. Heart rate variability, the short version of it is, and the thing that's confusing for a lot of people, and it's still hard for me to get my head around, is you don't want, like, I would have naturally assumed you want your heart rate to always hit like a perfectly timed metronome. You just want it to be perfectly the same over and over again. And it turns out that that's actually the opposite of what we want. We want our body to be able to respond to stimulus in a very dynamic way. We don't want this just robotic heart rate. So you actually want the highest heart rate variability that you can achieve. So if you're wearing a Whoop or an Oura Ring, or I think potentially the new Apple Watch is tracking these things, it's a better indicator of what's going on in your system and how well your body responds to stimulus than just one marker of, do you have apnea, or do you have this, or do you not have this? It's how is your body responding to the different stimulus throughout the day and throughout the night.
If someone wanted resources on airway dentistry, do you have any that you can share with us?
Sure. I mean, I think the Holy Grail to me is my mentor in this is Jeff Rouse. He has a course at Spear Education. I mentor that course from time to time, once or twice a year. I still think that's the absolute like cornerstone of where people should start. I don't want to be self-serving here, but myself and one of my good friends, Tracy Nguyen, who's a dentist out of Northern Virginia, we're starting a course called Airway Smile Design. And that's going to be the first course is in April, and then we have a sign up for people who are interested in future courses that we're putting on. Those courses I would say are the main ones for restorative dentists, for your everyday dentist. There's a course if somebody's a orthodontist, orthodontic surgeon. There's a fantastic course that I've also attended by two amazing doctors that teamed up. Rebecca Bacau is an orthodontist out of Seattle, and she and Mike Gunson, which, it's hard to put numbers on this, but like, if he's not the best orthodontic surgeon, I don't know who is, but they teach a course called something along the lines of Grow Healthy Faces. Mm-hmm. So, where I kind of focus on the more cosmetic aspect, because that's what pays my bills. That's what my patients are interested in. Their patient base is health first. So we get to the same destination in different ways. So, and then from a myofunctional airway, if somebody's interested in myofunctional therapy, tongue tie releases, anything from that category, or ENT, the Breathe Institute, which is also in LA, that they're doing really well. They might not need my mention, but Dr. Soroush Zaghi is kind of the holy grail of myofunctional therapy and tongue tie releases. So any courses by Breathe Institute, I would highly recommend. So which that extends beyond just the dentist, but now you have your hygienists getting into this as well, and you need your team in on this.
I'm glad you plugged in your course. I saw that it was in April, so it's quite soon. If someone was interested in getting into your course, where can they find information on that?
Thank you for saying that. So our April course is sold out. So we have a sign up sheet for all the future courses. So as more people join and we decide on locations, we'll be releasing that in the fall. But airwaysmiledesign.com, that's going to be the best place to go. And then I'll share a link that you can potentially share with listeners that they can get up on the sign up list.
One question just came to mind before I let you go. What do you think of Botox for masticatory muscles?
I was going to say I need it, but listen. So to answer the question, it's perfectly fine. Mm-hmm. Like, you will find that I'm pretty okay with everything. So it's a great Band-Aid. So again, the goal behind the treatments that we're doing is, as much as, I'm kind of becoming more and more synonymous with airway, I really approach things from a functional standpoint. I always want to ask, but why do we need to do this? So, Botox is a perfectly good treatment. It makes a lot of people feel better. It helps them get out of pain. But as anyone that's used Botox or administers Botox knows, the secret sauce of Botox is it wears off. Mm-hmm. So it's one of those things, and it's not particularly cheap. So the only issue I have with Botox is kind of that, which is somebody finds relief from it, and I don't want to say short-lived, because a couple of months is great to be out of pain, but you got to go back for more. And then it gets cost prohibitive for a lot of patients.
Dr. Victor, if someone wanted to connect with you, where can they find you?
Sure. So if you I'm on social media probably too much of my day, but you can easily drop me a DM. I will get back to you. I'm at Dr. Victor DDS. It's not the most creative handle, but can't change it now. I'm happy to share my contact information with your listeners as well, but Instagram tends to work super fast.
Dr. Victor, this was a fascinating conversation. Thanks so much for teaching me about airway.
It is totally my pleasure.
If you enjoyed this episode, be sure to follow our podcast, write a review, leave a comment. Anything you share with us goes a long way. And if you think a friend will appreciate this podcast, then make sure you share it with them too. Until next time, cheers.